heard this morning about how expensive, time-consuming, and lacking in sustainability the development of treatments for rare diseases can be. Sickle cell disease faces all of these barriers, but also is embedded in the context of structural racism in the US. So I'm going to talk to you today about understanding and addressing some of these sickle cell disease healthcare disparities. I have nothing to disclose, and my objectives are to understand disparities in health resources and outcomes for the population with sickle cell disease. And I'd like to give you some familiarity with strategies for addressing health disparities and achieving health equity for the population with sickle cell disease. So this quote from the National Academy of Medicine was almost exactly what I wanted. So it says, improving health equity requires a holistic approach, and change is needed everywhere. I added from the bench to the bedside, to the boardroom, to how payers pay for care, and to health policy changes. So we really do need a holistic approach in order to address some of the challenges with treatments for rare diseases, but again, particularly those characterized by health equity, health inequities, and health disparities. So you saw this slide that Dr. Walters presented that just really points out the impact of sickle cell disease across the life course because blood flows everywhere. Every organ has a potential for damage and ultimate failure. But this slide really points out as well how social determinants of health can impact people with sickle cell disease, because people with sickle cell disease are primarily Blacks and African Americans in the US. So they've been made vulnerable by systems of inequity, and these social determinants of health, or the conditions in which people are born, grow, live, work, and age, are disparately apportioned across populations within the US. And so particularly for Black and African Americans, there's a real complex interplay between education, wealth, the justice system, employment, and health. Looking a little bit closer at sickle cell disease disparities in health outcomes and health resources. First, in looking at disparities in health outcomes. And these just would include that the average life expectancy for people with sickle cell disease, particularly hemoglobin SS, or the most severe form, is a full 30 years shorter than that for people without sickle cell disease. People with sickle cell disease have the highest rate of 30-day readmissions compared to other conditions. And you heard about the tremendous vulnerability to complications, including stroke, infection, anemia, and pain, which I'll talk about a little bit more shortly. In terms of health resource disparities, the majority of people with sickle cell disease in the US are Medicaid beneficiaries, Medi-Cal in California, and physicians can make the choice to not accept these patients. And then further, healthcare providers inaccurately but too often perceive people with sickle cell disease as drug seekers rather than as people seeking relief from pain. So as a result, study after study has shown that people with sickle cell disease experience longer wait times to see a physician and to get that first pain medicine when they visit the emergency room. And then the number of physicians, particularly the number of physicians available to treat adults with sickle cell disease, is very limited still. So the roots of these disparities are in funding. And what I'll talk about is how funding really, not having adequate funding really hampers those moves from the bench through to the place where treatment is available widely. So if we compare sickle cell disease with cystic fibrosis, there are about 100,000 people with sickle cell disease in the US, and about 30,000 people with cystic fibrosis that primarily affects whites. So then we look at funding from the National Institutes of Health. And this analysis was published in 2020. It was done in 2018. So these are recent figures. So you see a problem right here. Sickle cell disease gets less than half of the amount of funding compared with cystic fibrosis, even though it affects many more people. And then when we look at philanthropic funding, the disparity is even more stark. So that people with the cystic fibrosis population gets tremendously more philanthropic funding compared with those with sickle cell disease. So that the average funding per affected person is less than $1,000 for people with sickle cell disease and about $10,000 for people with cystic fibrosis. And what this leads to is what we faced over the last decades, where sickle cell had only one disease-modifying therapy for like 20 years, and then one or two more were added. There are more in the pipeline now, but it's still, again, a major problem. So again, these disproportionate funding levels do lie in the system of structural racism in the US. Sickle cell disease was identified in Western medicine in 1910 and was coined the first molecular disease by Linus Pauling in 1949. But there were many discoveries and advancements that were associated with molecular medicine, and really none, if limited, improved the quality of life and quality of care for people with sickle cell disease. So racism is a system that assigns value based on how an individual looks or the color of their skin. It unfairly advantages some and unfairly disadvantages others. But it hurts the health of everyone by preventing some people from attaining their highest level of health. And racism can be intentional or not, so that it can affect health in many ways, from an individual provider's implicit bias to unfair policies, practices, and resource allocation, as you've seen with sickle cell disease. So the first holistic approach to improving sickle cell disease care that addresses this firmly rooted context of structural racism came with the Black Panther Party. The Black Panther Party was founded on one of the campuses of the Benioff Children's Hospital, Oakland. At the time, it was Merritt Community College. And the pillars of the Black Panther Party included the health of the community, and they adopted sickle cell disease as reflecting the unrecognized pain and suffering of the Black community. So their voices as activists, combined with the voices of Black community physicians, both here in the Bay Area as well as across the United States, to ultimately pressure the federal government to put funding into sickle cell disease care and research. So the Sickle Cell Anemia Control Act was signed into law in 1972, and 10 comprehensive sickle cell centers that focused on research, clinical care, education, and the community were established across the United States. So we were one of the first of those, we were one of those first 10 sickle cell centers. And it was a UCSF Cross Bay Collaborative, the Northern California Comprehensive Sickle Cell Center. Bert Lubin was the initial head, and Elliot Vachinsky assumed the leadership in 1978. And many of these, the comprehensive sickle cell centers were established in pediatric programs, and they were successful in that mortality in the pediatric years decreased by 3% per year. But treatment of adults was considered a community benefit program. And here in the Bay Area in 1999, the community hospital that was caring for adults with sickle cell disease abruptly closed. And the adult care was displaced to end up here at Benioff Children's Hospital in Oakland. So we have a lifespan outpatient program, but it poses complications for our adults because they can't be admitted here and go to the emergency room and inpatient admissions in the community, where they face lack of knowledge about their care, as well as discrimination and stigmatization. We relied heavily on that funding from the National Heart, Lung, and Blood Institute, but the National Heart, Lung, and Blood Institute abruptly ceased funding for the comprehensive sickle cell centers in 2007. And we had, again, relied on that funding, given that public funding still is inadequate and access to care certainly remains inadequate. And so where things have improved for children due to newborn screening advancements, mortality in adult years has increased every year since the 1970s. And of course, bias, discrimination, and stigmatization are significant issues. So I'm going to turn to pain and sickle cell disease. It is different from almost all other pain syndromes, with its onset in infancy and exposure of individuals to opioids early on. And this and other reasons lead to providers overestimating the risk of addiction for patients with sickle cell disease compared with other chronic pain syndromes in the absence of evidence to the contrary. And so as a result, individuals with sickle cell disease and their families consistently report that they're discriminated against, misbelieved, and mistreated within the healthcare system. And sometimes this leads to people avoiding necessary care. So how do we mitigate some of these healthcare disparities? For clinicians, a philosophy can be to approach patients with sickle cell disease with the understanding that they want and deserve optimal pain relief and the best quality of life. And in the acute setting, it's important to listen to patients and respect their self-reports. There is only self-report that's available in terms of pain assessment. Outpatient providers should co-create pain plans based on trust and patient family-centered communication. And then decisions about pain assessment need to be made based on the patient's history, not on looking at the patient and trying to decide how much pain you think they're in, but by listening to them, getting their understanding about what works for them and minimizing side effects. And the available guidelines do recommend individualized pain plans or sickle cell disease specific pain management protocols. And not only for providers, but for researchers as well. Cultural humility is an approach that can really change things for people with sickle cell disease. And cultural humility was first introduced, again, here at Children's Hospital in Oakland by Melanie Turvalon and Jan Murray Garcia. And it was distilled into these 5 R's. And so again, thinking as researchers about cultural humility, what are the research questions that we choose to study? How do we choose to approach people who we are trying to enroll in clinical trials? If we use this approach, we might have success in partnership with the community. So first, reflection. Approach every encounter with humility and understand that we can learn something from everyone. Respect, treating every person with respect and striving to preserve their dignity always. And so again, our young people, Brooklyn in the film talked about when they go to the emergency room, their dignity is not preserved when they're labeled drug seekers, when they have to change perhaps a stoic approach to their pain management in order to get the provider to pay attention to them. And so if we hold every person in highest regard while being aware of our own unconscious biases, that's an important third step. And understanding and expecting that cultural humility is relevant to every patient in every encounter, and avoid that labeling of frequent flyers and sicklers. And then finally, resilience can be fostered in all of us, not just the people with sickle cell disease and families that we serve, because it can really enhance our own globally focused compassion and our compassion with ourselves. So Dr. Walters alluded to this when he talked about the National Academy of Science and Medicine report, but there are national efforts as well. So remember at the beginning, I really talked about the importance of holistic approaches. And so these national efforts are holistic. First, a Sickle Cell Disease Coalition, which is actually global, and again, represents multiple sectors from pharma to clinical to researchers, individuals with sickle cell disease, community-based organizations, and so on. And the Cure Sickle Cell initiative at the National Heart, Lung, and Blood Institute is really focused on curing, but as well as understanding people with sickle cell disease. Again, the NASM report provides a strategic plan and blueprint for action. And the Sickle Cell Disease Implementation Consortium is also funded by the National Heart, Lung, and Blood Institute. And it's a consortium of 8 centers around the country that look to lessen that gap between discovery and practice. And within California, I can talk proudly about an effective partnership that we put together. So in 2018, we brought together clinicians, again, researchers, people with sickle cell disease, their family members, experts in policy, epidemiologists. And this is all over the state of California. We came together, about 52 of us in Sacramento, to discuss and craft a sickle cell action plan for the state of California. And the highest priority that was put forward was the need for better care for adults with sickle cell disease. So we, over the course of a year, worked together in multiple meetings to complete our California Sickle Cell Action Plan. And then our colleagues in Southern California introduced the Sickle Cell Action Plan to the Assembly. It was approved without funding, but the amazing thing was that in the governor's budget, funding was allocated for this program called Networking California for Sickle Cell Care. And so 10 new sickle cell programs for adult care have been established across California to this date over the last about 2.5 years. Well, some existing programs have been strengthened with this funding and some new ones created. So we aren't out of the woods yet, but this is a great start, and we're hoping that this funding will be reallocated for the next 3 years. And here at UCSF, our initial Northern California Comprehensive Sickle Cell Center was Cross Bay, and due to limited resources, that was not sustained, but we're revitalizing it now. So in fiscal year 21, about over 400 pediatric and adult patients with sickle cell disease have been cared for. We've educated providers and community members. We've specifically trained providers in strategies to mitigate implicit bias. And then the original pillars of the comprehensive sickle cell program are a part of our priorities: clinical care, education and training, research, and community. And we've added a focus on health equity and inclusion, and really continuing to address policy to ensure equitable access as well as disparities in patient experiences. And another tool I'll leave you with is the Antiracism framework. So currently our UCSF presidential chair is Dr. Kamara Jones, and she put forward this anti-racism framework when she was the president of the American Public Health Association, and she had been at the CDC as well. So the framework really, the first step is to acknowledge that racism exists and to understand that it is a system and it saps the strength of all. And as a system, we have to recognize and rectify historical injustices. And of course, sickle cell disease is a prime example of that. So resources need to be provided according to need. And as Dr. Walters pointed out, while deploying curative therapies, we can't lose sight of the cost of those therapies, but we also need to make sure that we don't lose sight of the lack of access to quality care for so many people with sickle cell disease. And then within our UCSF system and within the US, we can act together to dismantle racism in structures and policies, as well as by taking personal responsibility. So I'm going to close by pointing out that sickle cell disease is a rare disease in the US, but it is not a rare disease on the African continent. So with the 100,000 people in the US affected by sickle cell disease, more than 300,000 babies are born with sickle cell disease every year in sub-Saharan Africa, and many will die before their 5th birthday. So an approach to addressing this, the Human Hereditary and Health in Africa Consortium is an NIH Common Fund initiative. And so it's not just about research, but about improving care. Sickle cell isn't the only disease that they're focused on, but it's an important one given its commonality on the African continent. And the other aspect of the Human Heredity and Health in Africa Consortium is the focus on improving capacity of researchers and clinicians on the African continent. And so a project that I co-led was a partnership between community elders, the healthcare system, clinicians, and local researchers, where we gathered perspectives of stakeholders. Just like, again, Dr. Walters showed, it's important to look at what are people's views and opinions about treatments that we want to deploy. And we asked, particularly in this case, about newborn screening, as well as about disease modifying therapies, and found similar barriers, poverty, distance from centers for care and research, and as well the necessity of aligning interventions with cultural norms. So with that, I'd like to thank you, and I believe we'll be coming together for a panel discussion. Thank you.
I'm going to open up to the floor, but I do have a few related questions that have kind of come in around this global situation, as far as one of the questions is about what the prevalence is of sickle cell disease in African Americans versus people from the African continent, and how that relates.
Okay.
And then and on top of that, it basically, I guess, what's being done to address the disparities in, and diagnosis and treatments in the African continent instead as well.
Oh, okay. So 1 in 12 African Americans have the sickle cell trait. I think it's about 1 in, is it 400, Mark?
Yes.
1 in 400 African Americans will have a child with sickle cell disease, or that's the prevalence. And then Hispanic ethnicity or Latinx populations in this country are also have a higher prevalence of sickle cell disease. And in California, there are about 9,000 people who have been identified with sickle cell disease, not just on newborn screening, but through a CDC surveillance program. And again, about 12% of those are Hispanic ethnicity or Latinx. So on the African continent, this Human Heredity and Health in Africa Consortium has a number of components. There's sickle cell, the initials are SPARCO, which I don't ever remember acronyms, I'm sorry. But anyway, there's a consortium that's focused on care. And so they're developing clinical practice guidelines. They have started a registry, and that's a big challenge in the US, that we don't have a national registry. And so different countries in Africa are attempting to create national registries. And so, that's so important to know where people are and where you should be deploying these treatments. So that's one of the things. And again, the research in terms of actually a very big grant from NIH went to one of my colleagues, Solomon Ofori-Akwa, at the West African Genetics Medicine Center to map the genome related to sickle cell disease in West Africa. So, so there are a number of initiatives that are happening across the African continent.
Okay, great. I guess what is being done as far as, is there a place for continuous monitoring, diagnosis? Are there preventative measures that can be taken to moderate the disease as well?
Did you want to answer that, Mark, or should?
Sorry, I was looking at the question in the chat about why are we focusing on curative therapies for this disease in U.S. when most of the affected individuals don't live here at all, and I think it's a fair question, and we do spend a lot of time thinking about how we could adapt these curative therapies for application in Africa. A lot of it has to do with the high cost of the manufacturing, but there are ideas about how to use closed systems and automation to bring down that cost. And I think the cost of the reagents also will come down as these therapies get developed further. But it all rests on having a foundation of registry and knowing where the patients are and making sure they have access to regular supportive care. So that work that's being done now in partnership with some U.S. groups like the SPARCO that Marsha mentioned are a precursor to that. So the reason why we're not talking about it today is that it's in a very nascent phase of development and in application, but we haven't forgotten.
Great. Again, going back to the question, is there a place where perhaps curative therapies aren't available, but there's some sort of, where does perhaps somewhere in between there having this kind of continuous monitoring of sickle cell disease state, and are there any preventative measures that people could take dealing with the disease without a curative therapy?
Well, yeah, absolutely. I mean, and it begins with newborn screening and making the diagnosis as soon as possible, because with the advent of regular supportive care, that's comprehensive care and education about the disease, using prophylactic antibiotics to prevent life-threatening infections, and understanding some of the signs and symptoms of the more difficult complications that occur. Lifespan to age 20 is in some states the same as it is in those who don't inherit sickle cell disease. So that has been instituted, and with disease-modifying therapies that are coming online that were recently FDA approved, I suspect that will only get better. The challenge is what happens to adults, and maybe Dr. Treadwell can amplify this better than I can. But in the current context, many of our patients tend to disappear for lack of access to care, having competent physicians to deliver the care, being in places where cultural competency might or might not exist, and so how do we extend the successes in early childhood to lifespan? It's really the challenge for us, I think, in the next decade. And I'm going to pass the baton to Marsha on that one.
Sure. Yeah. So another disparity that I touched on, but is pretty stark within sickle cell disease, is the age disparity. So again, there was a lot of success with newborn screening and with screening for stroke and prophylactic penicillin and so on in the newborn period. But there is actually an increase in morbidity and mortality as individuals transition from pediatric to adult care. So the adolescent to young adult years is an enormous challenge in terms of people falling out of care, and again, having over reliance on the emergency department because they don't have individuals providers who really know how to take care of them, or who are willing to take care of them. And again, then the lifespan is still in the 40s in some places in the US, or the late 40s. And, that's pretty egregious that in the US that a population is falling that far short of, national life or lifespans. So, so yeah, the age disparities are pretty stark in sickle cell disease, and it's just really important to, you know, there are self-management strategies that people can be taught, but it's so important to have providers that you know, are willing and able to take care of the young adults and the adults. And, you know, again, in response to the question of why even talk about sickle cell in the US, given that it's rare in the US, well, you know, the cost to people with sickle cell disease in the US in terms of their quality of life and quality of care should not be ignored. The impact of structural racism that people saw more starkly again with COVID-19, it's been there for sickle cell disease in the US. It needs to be corrected. And there do need to be interventions on the African continent, but there need to be interventions right here in the US to improve that.
Yeah, absolutely. So Mark, I have a question for you on how the gene therapy approach complements other approaches like global blood therapeutics, small molecule drug.
Right. So in the short term, the small molecule approach is safer, has immediate benefit for a lot of the persons who take it, but it's only effective if you take it every day, and you have to take it for decades and decades. And that's the hallmark of a chronic illness. It's only well managed as long as you manage it well, and then it falls apart. And you know, the option of a one-time curative therapy, ideally delivered early in life, would accomplish a couple of things. First, you don't have to remember to take the pill every day because you've completed the definitive therapy. And the second thing is that it should, if it's effective, prevent organ damage from accruing over time. So it should translate into a longer lifespan with better quality of life. So that's really, but you know, deciding to do a treatment that you could die of in the short term, or that you could develop a life-threatening, if not fatal, form of leukemia from, is daunting. And so that's why it takes a lot of careful discussion and time to reach at the right decision. So the decision making is time consuming and important, and that's what's kind of unique about this disorder, I think, that's so important to accomplish.
And a follow-up question on the kind of gene therapy approach is, how could another approach be in comparison of re-expressing a fetal hemoglobin?
Yeah, so that's another idea that also has been enormously successful. So there, as it turns out, if the fetal hemoglobin, which is made before a baby's born in the womb, because it binds the oxygen more tightly than the adult hemoglobin, so it's a way to transfer oxygen from the maternal blood circulation to the fetal circulation. If that fetal hemoglobin persists after birth for any of a number of reasons, some of them are hereditary, that if it's co-inherited with sickle cell disease, it ameliorates the severity of sickle cell disease. In fact, it makes it much more like sickle cell traits. So there's a way to manipulate the genome such that the fetal hemoglobin is turned back on. And there have been a couple of clinical trials that have shown a significant clinical benefit to persons with sickle cell disease who've gone through that treatment. So that's a complementary approach to what we're proposing. The difference is that if for any reason that fetal hemoglobin were to shut off again after that modification, they still have sickle cell disease, so it would come back. Whereas in our approach, which we find advantageous, but it is an alternative approach, the sickle mutation is permanently corrected. So those are an important difference between the two, but both appear to have significant clinical benefit in small numbers of patients that have been treated so far.
Yeah, great. Well, we look forward to more data on that. I have another question here. Is there a genetic difference seen in sub-Saharan Africa versus that seen in the US of sickle cell disease?
Well, I'm not a geneticist, I'm a psychologist. And I know that yeah, there definitely are differences. So, for example, in Ghana, there is a higher prevalence of SC disease compared with SS, and it also varies from country to country, where you might see more SS or S beta 0 or S beta plus. But again, I'm a psychologist, so I don't know, Mark, if you have better insight into that.
Yeah, I really don't. I mean, the only literature I'm aware of has to do with there are associations with the level of fetal hemoglobin again that's co-expressed with the sickle cell anemia that seems to follow regions in Africa. It just depends on migration patterns and how genomes were established in those regions. Some are more severe than others. So the higher the F, the milder the disease. But in Central Africa, it has one of the most severe genotypes with very low fetal hemoglobin. So, but that's all I can say about the difference between Africa and U.S. Severity. And most of the migration follows the pattern that was present in Africa. So there's nothing specific to sickle cell disease in North America that I'm aware of.
Our next question is, what was the level of off-target mutation in CRISPR stem cells? And is this a concern, and how will it be dealt with? I'm assuming this is in addition to the insertion deletion. Yeah,
so the gene editing reagents are really efficient. So we get targeting on target modifications in 80 to 90% of the stem cells. So, and the ratio appears to be about 60-40, 60% indel or 50% indel, 20 to 30% HTR. So what we're exploring now in our manufacturing protocols, how do we change that ratio from more indels HTR to more equal numbers, because that should make it safer and more effective. But that's a critical issue. And unfortunately, our animal models are in vitro testing. None of them are sufficient or satisfactory in predicting what the clinical outcome might be when you balance those two, one positive, one negative factor in. So I think until we get to clinical trial, we're not going to know how safe and effective this is ultimately, which is scary, because you'd like to have confidence going into clinical trial that it will be beneficial, but that's not always the case. So that's why we always build into any clinical trial stopping rules. So if it looks like it's unsafe, we stop the trial, we go back to the drawing board and come up with a better approach.
Right. So next question is, some of the early CRISPR therapeutic approaches have focused on sickle cell. I've looked at is one of the more promising. What are some of the, reading this, it's looked at as the most promising applications of this technology. What are some of the non-scientific challenges for this? I'm assuming a curative CRISPR approach.
Well, I don't know if this answers the question, but one thing we've run into that's very interesting is that, particularly in the adults with sickle cell disease, that having that disorder is part of their identity, and they've learned how to cope and be resilient and run their lives around this disease. And then if we've cured it and they're no longer dealing with those facets of life, it's a part of their identity has shifted or even gone away. And there's really can be a strong reaction to that, because they're sickle cell disease warriors, right? This is their identity, and we worry that we've seen that in some cases we take away that identity. So that has to be considered and discussed and supported as they go through that transition, because it can cause depression and other reactions that are untoward. I'm sorry, I'm not sure I understand the question.
No, I'm not sure either. Yeah, not only respecting their decision, but the support going forward if they do get a curative therapy.
Yeah, I can add to that a little bit as well, that the challenges for people psychologically, again, if that's the focus of the question, can be a survivor's guilt, because at this time, still the access to this is quite limited. And so people know that many of their peers or colleagues aren't going to have access to these trials and ultimate therapies. And then the impact on the family as well, so that they're, no matter how much the trial supports individuals from a financial standpoint, they sometimes have to move away from their home, and the family is living in a family house, but they have to, it's expensive. There's an expense to it. So so those costs, we just had a meeting recently with people with sickle cell disease who both had participated in gene therapy, and others who had not and would not be able to as of now. And these were some of the things they brought up, besides the identity, also isolation, depression, and then a financial cost that can be hidden. So those are some of the things that were brought up.
Yeah, makes sense. Another question here says, we have known of the genes associated with sickle cell for decades. What are the barriers to finding a cure? I'm going to add on top of that. I mean, I think there's difficulties in curing all genetic diseases, but is there something specific about sickle cell that makes it more difficult?
Well, yeah, I mean, it's something we grapple with all the time. And we have a cure. We have a bone marrow transplant, but it's arduous, it's risky. You could die of the bone marrow transplant. So what we really need is that slide that I showed with the ideal cell therapy profile that's safe, effective, available to everybody, and effective in adults and children. And we just aren't there. So why aren't we there? That's a very good question, and some of it's for all the reasons that Marsha alluded to in her talk, and some of it has to do with where we are with advancing the science technology. The CRISPR technology is exciting because it's so efficient and potentially inexpensive. So that's kind of where we are. I hope it'll go faster in the future, but it's a fair question. Why don't we have a cure for everybody? It's weighs heavy on us.
Yeah. So I think that is our questions that have come from the audience. I'd like to, take this moment to have you say any closing remarks, any thoughts of where, people can take action, or any words of hope.
Thanks for having me. That's all I have to add.
Well, I'll say words of hope again in this meeting that we had at the beginning of 2022. The individuals who had gone through the gene therapy clinical trials, they did talk about the challenges, like the pain didn't go away right away, and they had to plan for having children later. They had to plan in advance. But every single one of them said they would do it again. So, and it was quite a few people there, and every single one said they would definitely do it again, that they grappled with the identity, the hidden financial costs for their families and so on. But they definitely said this is hope for people with sickle cell disease, and they embraced that for their own lives and their own futures.
Great. Well, thank you. Thank you so much to both Dr. Treadwell and Dr. Walters for joining us and discussing sickle cell disease.
Thank you.
Appreciate it.
Thank you very much.